Hello, hello, hello. It's Beth Wright, and I am providing you a podcast for Chapter 31, Unit 3 of NUR 237. So we're going to be talking about drugs to help with asthma and bronchoconstriction. So we're going to talk a little bit initially here about a few of the medical conditions that will require these types of drugs. So, asthma and COPD. I wanted to list your exemplars first. We have the adrenergics. Now, you'll see this referred to as beta 2 agonist, beta 2 adrenergics, but in your syllabus they're referred to as adrenergics. Okay, and so we have the albuterol, the epinephrine, the levobuterol, metoprolol, and terbutaline. And then we have anticholinergics, ipratropium and tiotropium. And then we have your Xanthines, those are your theophylline medicines. Then we have our corticosteroids. Then we have our leukotriene modifiers and mast cell stabilizers and immunosuppressant monoclonal antibodies. And then we have a combination of medicines. So let's talk a minute about these disorders that require these types of medicines. So we're talking about airway disorders, airflow disorders. And so with asthma, what asthma is a chronic inflammatory disorder that causes an intermittent and reversible airflow obstruction of the bronchioles. And so we see this affect children, we see this affect adults, older adults, and it can be quite debilitating and quite scary because folks can get into an emergency situation and got there the status asthmaticus. That's where they have a severe attack, and death will happen if it's not treated. And so the person with asthma, must have a very strict plan of care that they got to follow, or else they will, get into that status asthmaticus situation, and we don't want that, obviously. So your textbook does a great job explaining about asthma and the control of asthma as well. We have the COPD, chronic obstructive pulmonary disease, and I know you've heard of that many, many times and heard of asthma as well. The COPD includes your chronic bronchitis and emphysema, and this is where they will have the bronchoconstriction and inflammation, but on a more constant level and less reversible. And so with the COPD, we start seeing physiological changes, and that's where we talk about the barrel chest and things like that. So both of these are conditions that will require medications to help treat that. Now notice inflammatory is in both of these, or inflammation. So think back about the immune response and inflammation, the inflammatory response. What happens there? So bronchoconstriction is one thing that happens with that inflammatory disorder, inflammatory response, as well as an increase in mucus production, as well as a whole lot of things. Histamine is released, and again, it's the body's response to inflammation is meant to help, but as you know, there's a lot of those responses that causes problems, and so we have to give medicines that kind of shuts off that inflammatory response. And one that you know about is the corticosteroids, and that's one of your treatments here. So anyway, we're going to focus on the medicines used to treat these different disorders. Now, of course, I found some pictograms to help with this, and you may see asthma also referred to as reactive airway disease. And with asthma, there's those triggers that can start this process happening. Anything that causes an allergic reaction, a hypersensitivity reaction, an upper respiratory infection, exercise induced asthma can happen. Air pollution, so you see on the news, a lot of times they'll give the your rating of air pollutants in the air. Of course, respiratory infections and GERD, gastric esophageal reflux disease, that's been shown to stir up the asthma for folks. And we can see those signs and symptoms there. Hypoxemia is a concern, of course, and tachycardia, increased restlessness, and tachypnea. When someone has an asthma attack, they are coughing, there's increase in mucus, they're definitely short of breath and tightness in the chest. In the early signs, they have a low PA carbon dioxide level, but in a late sign that can go increase. Wheezing, we're going to hear wheezing because of that bronchoconstriction. It's hard to get air in something that's small. If you're sucking in a straw and that straw is bent, you can't get air in. So same thing with this, wheezing and retractions. We may see retractions there. Certainly accessory muscles in use. And of course, in the emergency situation, in that status asthmaticus, that can be life-threatening. We got to get those folks treated ASAP. And then here's a pictogram of the chronic bronchitis. So again, these are more chronic issues where the situations that occurred, are more chronic, and so now we've got that inflammatory response that's happened time over time, continuously happening. And so what happens with continuous inflammation is scarring happens, and so we start getting a physiological situation that occurs. You can see with chronic bronchitis, patients can be, they're going to have a recurrent cough and sputum production, hypoxia, hypercapnia, exertional dyspnea, meaning that, if they get up and walk across the room, they're going to be short of breath. Of course, smokers are prone to this for sure. The digital clubbing, meaning the fingernails club, and that's, of course, a late sign of hypoxia. It can cause cardiac enlargement. We're going to see those accessory muscles used, and it can lead to right-sided heart failure as well. And then we have the emphysema as a part of that COPD, and this is where the alveoli are having problems with the diffusion, and so these clients retain that CO2, and you're going to see pursed lip breathing and dyspnea and elevated heart rates, orthopneic for sure, the barrel chest, because the barrel chest has happened over time, that physiological changes that occur. They too will have that exertional dyspnea. It's going to be difficult for them to breathe and talk at the same time. So you might see these folks short, jerky sentences, very anxious, and maybe very agitated as well, easily. And using accessory muscles to breathe is certainly going to be something you'll see. Okay, so bronchoconstriction is resulting from spasms or constrictions of that airway. And if you look at the bronchioles there, the one on the right, look how how that airway is narrow compared to the one on the left, for sure. And so when that happens, we're going to feel short of breath. And these diseases that we're talking about are times that, when the patient's going to have bronchoconstriction. And prevention is critical, especially with our asthma patients, because those are reversible. So prevention is critical. And rescue treatment is a matter of life and death. So a peak flow meter is an instrument that's used to help document the amount of lung air in the lung volume. And so this is something that's used for asthma patients, and it can help us document or help the client document how they're doing with their medications and possibly warn about impending problems that would turn into an acute situation. And I put a YouTube video on your unit for this chapter to show how that is taught to the client and how they should record that and use that to help them. So it can also let us know that treatment is working too. So we need to do teaching with the patient and, of course, do a return demonstration so that we know for sure that they can use the instrument properly. We also want to talk about anything that might stimulate exacerbations of the asthma attack, such as smoking, any kind of allergens, the GERD, exercise, or any kind of medication. Medications can definitely stir this up for patients, especially the ASA is initials for aspirin. So that's a common medication that can cause problems for asthma patients. So never assume that the client knows how to use the medications here. And what we're talking about, we have the meds, the bronchodilators. They come in the PO form. They come in the meter dose inhalers. They come, a lot of them come so that they can be given by nebulizer. And so we can't assume that patients know how to do that. And think about your elderly patients too. The inhalers require some dexterity of the hands. And so, we have to be coordinated and do teaching with the patient there. So the inhalers come in many styles and shapes, and we got to explain the use of that and make sure that we know the client understands it and have them do a return demonstration. And likewise with nebulizers too. So another pictogram here. I got a lot of pictograms in this presentation, but anyway, you can see there is a spacer, and I've got another picture of the spacer. The spacers are used to help keep that medicine that's in the meter dose inhaler contained, so that it's not lost to the atmosphere or environment. So the meter dose inhaler is like a pressurized container, and they have to push down on it, and there's teaching in your book that you need to be sure to read about. And again, the spacers used to help the effectiveness of that drug delivery. The dry powder inhalers are where there's capsules or tablets that's crushed in the inhaler container, and then that dry form of the medication is inhaled. And then you have our nebulizers that where there's equipment involved and it's liquid medication that turns into a mist, and that mist is then inhaled by the patient through a mouthpiece or a mask. So let's talk about rescue treatment, and their adrenergic meds are what's used for that. Okay, so the rescue inhalers, they work really quickly, 5 to 15 minutes they start working, and we have to be careful about excessive use of these because of the adverse effects of the medications, and it needs to be letting us know there's a problem. We're not controlling or maintaining the asthma if the patient is having to use the rescue inhalers more than what's indicated. So we have to be sure to know that. That also, if they're having to repeat it, we need to be sure that they're using the medication right, or are they using the inhaler correctly. So we need to, it tells us things when patients are having to use those rescue inhalers more often than what's going on. So one being poor use or inappropriate use of the medication, and the second might be that the patient's being exposed to those stimulants that are stressing out the airway. And so we have to do teaching about, avoiding those things that trigger the asthma. And stressors can also be viruses or infections, so they need to be worked up for that kind of thing as well. So this is an example of one of your rescue medicines, the albuterol. And again, it works rapidly, and it's going to be the first drug used to get control of that, okay? Because what it's going to do is it's going to open up, it's going to dilate those bronchial tubes so that the patient can get air in. So for rescue, we're going to use that inhalation, the inhaler there, or the meter dose inhaler, if you will. And it works really quick. It works faster than the oral form, so that's what we're going to use. And these are referred to as your short-acting beta adrenergic agonist. If the patient is on a routine of more than one inhaler, then they need to wait 5 minutes before they use the other. And they need to keep this with them at all times, okay? School, car, work, wherever. They need to keep it with them. Now, your other adrenergics that's listed as your exemplars are the epinephrine, which is short-acting, and it can be given sub-Q, and it can also be given IV. The levabuterol is another short-acting that can be used for both prevention and treatment. And you also have the metoprosterinol, which is an intermediate-acting beta-2 adrenergic agonist. That can be given either by PO med or meter dose inhaler, and that's used to treat acute and exercise-induced asthma. You also have the terbutaline, and it's interesting that this medicine has been found, although it's not FDA approved, has been found to help with premature labor, to stop premature labor. But it's also used as a long-acting bronchodilator. Okay, so again, we want to be sure the patient understands and can demonstrate the use of the inhaler. That's going to be important because, if they're not using it correctly, then it's not going to be beneficial. So we want to make sure they know how to use it, how often they need to use it, and document the use of, so that that can be monitored and managed to make sure that we're not having some additional problems. Also, with these medications, they patients need to avoid beta blockers, such as metoprolol. Those beta blockers are your ones that end with that OLO at the OLOL, sorry, at the end of them. So, because we're giving a beta agonist, we don't want to give a beta blocker that's going to block that, right? So beta blockers also have side effects that can, um, cause issues here for these patients. That can cause bronchospasm. So asthma patients, COPD patients, they all need to, kind of avoid those, those types of medicines. Also avoid any other stimulant drugs, because one of the adverse effects is that these medicines definitely stimulate. So caffeine is a stimulant, and then also avoiding the MAOI inhibitors that talks about in your book too. They should not take those 14 days within each other. This is an example of the spacer that's provided there. And again, so we need to show the patient how to use this. And this has been proven to help be sure that the patient gets the medicine instead of the atmosphere getting the medicine. So our adverse effects with these, with the adrenergics, they definitely have that stimulant effect, and so we're going to see some tachycardia, possibly angina, and we got to watch about patients, contraindications for patients with pre-existing coronary artery disease. So we've got to do those vital signs before and after the treatment. Also, central nervous system stimulant. Stimulation is going to occur. You may see anxiety, restlessness, tremors, insomnia, and also it talks about caution in use for patients with hyperthyroidism due to the cardiac effect, seizure patients, and diabetes. Again, we need to recognize that beta blockers interact with this medicine, so those need to be avoided. With our with this whole type of plan for patients, we need to definitely talk about what causes exacerbations of the distress and avoid those with that, with all that we can do so that we don't get into a severe situation. Okay, our anticholinergic bronchodilators. The medication here is the apotropium, and this is used for long-term bronchodilations in patients with asthma, COPD, and bronchitis, and it can be given by nebulizer or inhaler. And it can be used, it's typically used in conjunction with other medicines. The onset is fairly quick, 5 to 15 minutes. But the peak effect is 1.5 to 2 hours. So it is not a recommendation for an acute attack as a single agent. So adverse effects of these meds, cough, nervousness, nausea, GI, headache, and diarrhea. Tiotropium is also another one that's used in this class of drugs. And note that the patients should not take those together at all, because mixing or combining two anticholinergics can certainly be dangerous for patients. This is your tiotropium. The Spiriva is the trade name. You may have heard of it. And so this is one of those dry forms of medications. It is a long acting, so it's once a day, and its primary adverse effects is dry mouth, headache, dizziness, abdominal pain, flu-like symptoms, and chest pain. And so they literally place a capsule into the little chamber there at the top, and it's pierced. In other words, a little holes put in it, and the patient then inhales 2 to 3 times until they hear a flutter, and that means they've got the medicine. And the patient will tell you, "Yep, I got it." Okay, the xanthines, these drugs, you don't see them used as much anymore. We used to use them quite a bit, so they're pretty much considered our second line of defense these days, and the main reason is because of the toxicity potential for them, because there's a very low or not low, but narrow therapeutic margin there. If you look at the drug level, 5 to 15 is therapeutic, and anything over 20 is toxic. So that's a pretty narrow therapeutic level there. It can be given oral, or can be given IV as well. It definitely has a stimulant effect, and so we need to avoid those other things that might stimulate, like coffee. Its uses include asthma, COPD, bronchitis, and emphysema. Dosage adjustments, and for smokers, the dose needs to be a little bit higher. But if a patient is stopped smoking, then that dose needs to be modified or reduced. It's metabolized in the liver and excreted kidney, so function of that area needs to be monitored. And then, of course, side effects are nausea, vomiting, convulsions. So we've got to be careful if this patient has any kind of history of a seizure disorder. If toxic, they can have dysrhythmias, tachycardia, and note there are numerous drug interactions with this type of medicine. Corticosteroids, so you know about those. You've had those before. You're going to have them again and again and again. But we use corticosteroids a lot with bronchoconstrictive problems or respiratory problems because of the anti-inflammatory response. And it does decrease the edema and that kind of thing. Decreases the mucus production. And it can help repair the damaged epithelial with subsequent reduction of airway reactivity. So it's most consistently effective with long-term control medications with asthma, and we can do IV forms in the acute situation to, kind of get a control over that. The oral forms are available, as well as the meter dose inhalers. Of course, with corticosteroids, there's a ton of side effects, and one being that it can stop that adrenal function where the cortisol is released, and so what happens is the body, if we're giving exogenous cortisol, cortisone, corticosteroids to the body, then the internal body says, "Hey, I don't have to produce this anymore," and it can stop that function of the adrenal gland and cause an adrenal insufficiency. Also we need to be monitoring glucose levels because it will increase that. It reduces the immune response. We know that already. And just a ton of those side effects with corticosteroids. So, we have to be sure to monitor for these things. It causes retention of fluid, and so we know to check blood pressure for that reason. Now, when patients are on these medications, they do not need to stop them abruptly because, again, of that concern of the adrenal insufficiency. So they need to be weaned off of that or tapered down. And again, the impaired immune response, we know already that happens, and so the patient is at risk for infection. You see that more adverse effects here. Cough. Candidus is oral fungal infection can happen, and a way to prevent that is that the patient needs to rinse their mouth and they need to clean their inhaler. So they need to be sure to do that. And of course, using the lowest effective dose of corticosteroids is what's going to be important as well. You can see your pictogram on the right there, the good, the bad, the ugly. And so be sure to read that. These will be in your notes. It gives you, again, with the ugly, it gives you the numerous adverse effects that can happen with your use of corticosteroids. Leukotriene modifiers. Now, leukotrienes stimulate, they're part of that immune system and the inflammatory response that causes the bronchoconstrictions, it causes swelling and edema and mucus production. So these medicines are leukotriene modifiers. They are also known as leukotriene receptor antagonist. Okay, so Montelukast is your prototype and your exemplar for this. These are often used with patients who are poorly controlled with other medications. It's definitely not for a rescue acute asthma attacks. It's more for preventative or prophylactic. And of course, you see your adverse effects there: GI symptoms, headache, infection, sore throat, ear infections, that kind of thing can happen. It is given in oral form, and there are some drug-drug interactions that can occur. So this medicine can be used along with steroids and bronchodilators as well. Your mast cell stabilizers. These, first let's talk about what are mast cells. And so you see a picture there. Your mast cells are a part of your leukocytes, and they contain histamine and other chemicals that come to the release of, or to the rescue for inflammation in the body. And so the mast cells stabilizers are used to stabilize that mast cells and prevent that bronchoconstriction from occurring. They're used as alternatives and can be used prophylactically and to prevent acute asthma attacks, but not a rescue inhaler. Use of one of these drugs may result in reduced dosage of a bronchodilator and corticosteroid, so that can be helpful. There can be serious toxicity that can happen with this, so we need to be watching about that. Signs and symptoms of adverse effects are dysrhythmias, hypotension, chest pain, restlessness, CNS depression, anorexia, nausea, and vomiting, and sedation and coma can occur with overdosage. And then we have our immunosuppressant monoclonal antibodies, omalizumab. Those are mouthfuls, aren't they? And you remember about the MABs, M-A-B at the end. Those are immunosuppressants. And so when we're talking about the monoclonal antibodies, these work to work in the immune system, and so they have taken the monoclonal antibodies to suppress the immune system, to get it to decrease response and the inflammatory response as well. With this medication, there is a black box warning contained with that. It cannot be given at home. It has to be administered in a healthcare setting because of the potential for life-threatening anaphylaxis reaction. Okay, and then you have a combination medications that are commonly used, and the main thing about that is, that it can help with the patient having to take smaller doses, and it may also decrease adverse effects anytime we take a lower dose of that. And also it can help with patient adherence to the game plan for sure, and gives you a list of those medicines there together. Okay, so evaluation, just measuring that effectiveness, and also what we might see in adverse effects, because evaluation of our clients is extremely important and a part of that nursing process. And so if patients are having to use bronchodilators for bronchoconstriction, what are we going to see if we feel the medicine is working? And so if you think about this and what we're going to be checking, obviously our assessment, we're going to be doing, a really good respiratory assessment on the patient, those vital signs of pulse ox. We're going to possibly see ABG results. For our asthma patient, talking to them about their peak flow meter and looking at those readings. And we want to get a good history on them. What's been going on? Do they have a decreased number of attacks requiring rescue drugs? And also, again, the patient using the inhaler the correct way, or the devices, whatever it may be. With our adverse effects, making sure that they're not experiencing that tachycardia, nervousness, anxiousness, tremors, palpitations, agitation, insomnia, those cardiac effects as well. And so we always have to be on alert for adverse effects, and also assess for that effectiveness of the medication. Okay, that concludes your podcast.